John. Can you all hear me? No. Am I on yet? Here, how about now? Is that better?
Barely.
Barely?
There you go.
Barely? Can you hear me now?
Barely. You might have to hold it.
I may just have to hold this then. Yeah, unfortunately. I am Benjamin Domenech. I am the managing editor of Healthcare News and a research fellow with the Heartland Institute. I wanted to quickly introduce what I think is a really excellent panel that we've gathered together for you. First, immediately to my left is Jill Vecchio. She's here from Colorado. She's been with Docs for Patient Care for how many years, Jill?
2.5 years.
2.5 years. And she additionally does a bunch of projects with Doc Squad. She's a political activist, very engaged in state-level debates over healthcare policy. To her left is Judson Hill, senator from the state of Georgia, and really a leader on healthcare issues, policy issues at the state level, and somebody who has a lot of experience on these matters and can speak to the legislative response over the past couple of years. And then at the far end, Christie Herrera, may be known to you for her work with ALEC over many years. She is now most recently with the Foundation for Governmental Accountability, which is based out of Florida. She is still, thankfully, up near me in Virginia and the DC area, so I still get to see her from time to time more regularly than I would if she was down there. But she's been totally engaged on all of these issues, Medicaid reform and everything else, over the past several years, and can really speak from experience. I want to start by just giving you a little bit of a perspective on where we are today. Obviously, when the Supreme Court decision came down, I think many of us were surprised and disappointed. How many people were surprised and disappointed by that? All right, okay, yeah. Well, we're all in this together. So here's the thing that's interesting about that, and I've now gone and traveled to several states to talk about these issues in the wake of that decision. I'm amazed time and again by the number of citizens, not just legislators, not just people who do this for a living, but citizens who are incredibly well versed in these areas of policy. They care about these things and they paid a lot of attention to them. And so I was in Arkansas recently and met with probably a total of 800 people over the course of like 2 days talking about these issues, and you would be surprised the number of people from Hot Springs who have very strong opinions about federalism and about Chief Justice Roberts. So, if there is one silver lining to all of this, it's let's say the education process has been furthered. But there are some additional silver linings, and the most prominent of them, from my perspective, is the surprise decision, the 7-2 decision, in favor of giving the states the kind of authority that those of us in the conservative and libertarian movement have argued for years that they already had, which is that essentially the federal government cannot bribe you with your own money. And from our perspective, what that really means when it comes to the Medicaid expansion is that states have the opportunity to decide really for the sake of future generations what kind of burden they're going to give them in terms of the costs of expanding this program, which is already stretched too thin and already has terrible outcomes. The Medicaid expansion has only been accepted thus far by 10 states, all of them hard blue states, and there are roughly 7 states that have already said that they are not going to expand Medicaid, and there are additional states, including some Democrat-led states, which have already said that we think we're going to hold off at least until November to see what happens, Missouri being one of them. There's all sorts of activity at the state level right now where providers are essentially arguing that that they cannot survive without this new money. And where senior officials within Democratic administrations are making the argument publicly that it would be ludicrous to reject this amount of free money. What people understand at the state level is that it is not free money, that there is no such thing as free money. And what's more, they understand that whether we're talking about 60-40 matches from the government or whether we're talking about 90-10 matches from the government, 100% comes from them. That's something that I think many people are beginning to understand about this. This is not money that comes from nowhere. So in terms of the decision process that we're seeing at the state level, as these analyses go forward about the amount of money that the feds would be sending compared to the amount of money that the states would be paying, The reason that you see governors like Rick Perry, governors like Governor Jindal and Governor Scott rejecting these things so outright is that what they understand is that in order to fund this kind of expansion, they would have to find a way to do that within their state. What that means in a state like Texas is $27 billion. What that means in terms of their budget is that they would have to find that $27 billion. And the way that they would do that is probably by having to create something that they famously do not have, an income tax, which of course is the sort of thing that scares anybody away from free money. So that's obviously one major issue. The other major issue is the exchanges. In terms of exchange implementation, we now find ourselves at a point where states really do have the ability and the authority to block exchanges to a greater degree than we really ever anticipated. We've been arguing at the state level for the past several years that exchange implementation is not something that people should do under PPACA, that essentially there is no ability for the exchanges to have a state exchange under the regulations that are required there, that all it really does is cede control and power to Washington while leaving you holding the bag in terms of the administrative costs and the actual burden of running it. That's an argument that has been surprisingly very successful. As of this moment, only 13 states have actually submitted their applications in time in order to create an exchange. This essentially puts them, and keep in mind, those applications are due by mid-November. So in terms of state progress on this, we're really not seeing states even at a point where they could do it, even if they wanted to. And even the states that do want to push ahead with this, many of them are admitting that they're so far behind in terms of the kinds of things that they need to do that they're not going to be able to achieve it in time. So those are the two main issues that states are faced with in terms of the decisions that they have to make within the next 6 months to a year. And what I'd like to do today is to run through a couple of questions to our guests about what they've seen at the state level in terms of reactions to the decision, in terms of the Medicaid expansion, in terms of exchanges. And then I'd like to throw it all open to you because I'm sure you have many questions for them as well. And I'd like to start actually on the end with Christie, if I could. Christie, I wonder if you could speak to what you've seen in terms of the reaction to the surprise of the Medicaid expansion decision, this new ability that states have to make a determination in that. And maybe in addition to that, you could give us a little bit of guidance about your experience working with FGA on their very unique Medicaid reform plan, one which I think ought to be looked at by a lot of folks at the state level.
Sure, absolutely. Can you all hear me? I'm gonna hold it.
You may just have to hold it like me.
Yeah, can you all hear me now? Okay. Well, thank you to everyone for being here. I know that at 2 o'clock after a big lunch, the default is to go up to your room and take a little nap. So thanks for joining us to kind of be depressed together, as Ben said, about John Roberts and his awful, awful decision. Thank you, George W. Bush, again. But as far as the Medicaid expansion is concerned, I think there is a lot to be thankful for. And, you know, the rest of the decision had a lot of downside, but the Medicaid decision was an upside. That's because there's something called maintenance of effort that is now in play. How many of you know what maintenance of effort is? A few of you, okay. Maintenance of effort is a federal law which was started when SCHIP was reauthorized. It was renewed during the stimulus, and it was also renewed during the Affordable Care Act. In each of those laws, maintenance of effort was in it. And basically what it says is that states cannot change one iota of Medicaid eligibility, how you determine Medicaid eligibility or Medicaid benefits. And if you do, you'll lose all of your funding. So basically what the Affordable Care Act did was that it said, states, you're going to expand Medicaid up to 133% of the federal poverty level. Now what does that mean? It's about $30,000 for a family of 4. And if you don't do that, we're going to take away every dime that we give you for Medicaid, which is pretty significant. And, you know, we had a lot of states talking about opting out of Medicaid, but really that's not the best political I mean, in Libertopia, right, we all want to opt out of Medicaid and see people get private insurance, but we live in the real world, and in our state capitals that will never, ever fly. The good news about the Supreme Court decision is that some states have looked at it and they've said, you know what? John Roberts' decision on Medicaid, by saying that states don't have to expand it, in order to maintain their Medicaid funding, that decision means that that maintenance of effort goes away entirely. Why is that? Because Medicaid is a contract between the states and the federal government. Both parties have to agree to the terms. And what the ACA decision said, the Medicaid decision said, is that the feds can't, quote, surprise participating states with post-acceptance or retroactive conditions. That is exactly what maintenance of effort in Medicaid does. It imposes new requirements on old money. The Supreme Court said that is unconstitutional. What does that mean? It means that maintenance of effort is in play. It means that you can do what the state of Maine is doing. Is Andre here in the room? Andre Cushing from Maine? We have one Maine state rep here today, and Maine is taking the federal government to court. They have said, we looked at the decision. We think we can trim our Medicaid eligibility because John Roberts told us that we could. And if you don't agree with us, in 30 days, we'll take you to court. There is a great legal opinion that I can share with you. Just send me an email, Christie at floridafga.org, and I'd be happy to get it to you. But you know, there's a lot to be thankful for, and Maine is one example. I think that shows that the healthcare fight really has only just begun. The Supreme Court hasn't ended anything.
I want to ask you, Judson, in terms of what you've seen in Georgia, what was the initial reaction like among legislators there to the decision? And what, in terms of the implementation side, what stage are you sort of at there? And because I think it would be good to sort of hear some, I'm sure we'll have additional questions based on the various states, but just give us this snapshot.
Okay, thank you. And thanks for the opportunity to be here as well.
Thank you.
Appreciate all that Heartland does and all that y'all do individually. The words out of my mouth would probably be the same out of everybody else's that are serving in the legislatures across the country, and especially in this room. And that's, we were pretty much appalled and stunned. Mm-hmm. You know, with the Supreme Court's decision, it was, you would hope that the makeup of it, we thought that the decision was going to be made other than by Justice Roberts, obviously, and when he came down with that. And I don't buy into all the political games that people have speculated thereafter. I mean, you need to rule on the law, you need to rule on it the way you see it today and not try to set something up for a November election. I don't think that that was the case. Now we're hoping that that will be the result, but I don't think that's the case. Right? Raise your hand if you don't. I'm not putting you on the spot. If you don't. Yeah, if you do. So then it's what next? I mean, other than take the White House and take the U.S. Senate, what next? And states have a lot of issues that they need to wrestle with. The state of Georgia has not declared that they will not be creating a state exchange. I'll tell each one of you here, and listen, but I'll tell you that you need to oppose strongly the implementation of the state exchanges in your own state. There'll be no difference. It's a myth that the states will have some control over their health insurance and health care if they choose to voluntarily implement an exchange. Actually, it's the opposite. The regulations are the same. They came out with the regulations a while back now, and they're just as stern if you have a state exchange as if you have a federal exchange. And we need to put the burden on the federal government, I believe, to go into each one of our 50 states and take that bureaucratic burden and financial burden and try to do this in each state. I think it would be extremely challenging practically, but there's no benefit to the state to creating a state exchange from the regulations. It'd be identical regulations that'll be dictated and mandated solely by federal bureaucrats. And moreover, they'll have to, if you have employees, I believe it's a 50 employee limit for an employer. If you have a state exchange, then you're going to have to pay that penalty of $2,000 per employee. If you let the feds come in, my understanding is that that penalty does not apply to your state. So if you're interested in the business community, the small business community, and the individuals and the employees there, don't do it. If you're interested in your state pocketbook, don't do it. So.
Thanks. Now, Jill, I wonder if you could speak a little bit to the physician reaction that you've seen among that community and folks in terms of what they're doing in response to the decision, what they plan to be doing over the next several months.
Well, it's interesting. I think you can hear here. So I'm in Colorado, and unfortunately, we had with bipartisan support the passage of our state health care exchange, and as of yesterday, we have Dr. Janak Joshi, who's a Colorado representative here, and he's known as Dr. No in the legislature. He gets it, but I think you guys got a text today that said that they just passed another grant for the state of Colorado exchange of another $43 million of my taxpayer dollars and yours too, to further the exchange when they actually had an opportunity to kill it. So we've not been getting the support from our Republican leaders. Physicians in Colorado have been, unfortunately, quite asleep and uninvolved in following their Colorado Medical Society. And you all should know, as legislators, that the state and county medical societies in your state are tied directly to the AMA. They take their marching orders from the AMA. Only 9 states opposed the PPACA law after the AMA came out and endorsed it. 9 states went against their mothership and said, no, we disagree with you. We are not going to support this. The rest of them are all in step. So your state medical societies, if you oppose PPACA, they are not on your side, and they are not going to help you, and please do not step up and try to work with them. I beg you. They do not represent practicing physicians. As in Colorado, our physicians are members of the state medical society because we get a 10% discount on our medical legal liability insurance premiums if we're members. So a lot of times, like in my radiology group, I don't even have a choice not to be a member because our group needs that 10% discount. You're talking about close to $100,000 a year that it saves our group to be members of Colorado Medical Society. So follow the money, do the math, okay? Unfortunately, physicians have not been engaged as much as I would like, but they are getting engaged now because I think the entire country was hoping the Supreme Court would save us from this. And in that respect, I think Justice Roberts had a great comment when he said it's, we have a law that we deserve because we elected people that put this into our laps. So now it's time for us to all engage and get rid of it. But physician, I can tell you, I talked to our hospital administrator, and it's a county hospital. Our community hospital has been around for over 100 years, very well established, very little, if any, competition in the region. Our numbers for hospital numbers in the emergency room, 25% private pay, 45% Medicare, which covers our expenses as providers about half the time. So half the time it covers our expenses, half the time we lose, or we can make a little bit, lose a little bit, so it's really kind of a break even for Medicare. The other, 15% is no pay, self-pay, which is no pay in the emergency room. You don't get anything for that. So 15% of our business we're doing with no reimbursement, and the remainder is Medicaid, which we always lose money on. So if you're talking about expanding Medicaid, you're talking about forcing providers to lose money on every Medicaid patient they see. All we're doing is losing more money on more patients. It would be cheaper if you said to me, get out your checkbook and write this person a check for their health care insurance, because then I wouldn't have to be funneled through the federal and state governments to get there. But
I want to go back to Christie for a moment. When you moved to work for FGA, one of the things that's really been interesting there is the pilot program that's been running in Florida for a while. I wonder if you could speak about that for a little bit, because I think, I'm not sure how many people are familiar with it, but it's very interesting.
Sure. Do we have anyone from Florida in the room? We have 2. Okay, terrific. Well, then you know about Florida's Medicaid reform pilot program. And this is something that I think politically is really interesting. It originated when Governor Jeb Bush was governor of Florida and his brother was in the White House. Jeb Bush decided that he needed to make a change because in 10 years' time, Medicaid would consume 60% of the state's budget. They were operating something like 25 Medicaid waivers. There was all kinds of fraud and abuse, and he said, we need to make a change. In 2006, they started this Medicaid reform pilot project in 5 counties. And they said, you know what, so many of this Medicaid reform that we're seeing in the states is in urban counties because that's where the people are and that's where the action is. We're going to try this in rural counties as well. So they picked 2 urban counties and 3 rural counties. 5 things in Florida Medicaid reform. 1 is patient choice. A lot of times you think of Medicaid managed care. The federal minimum is 2 plans that you have the choice from. The federal government says you need to give people the choice of 2 plans. In Florida, they can choose from up to 11 plans. So what are you doing? You're voting with your feet. You're keeping plans accountable to patients. You're keeping the plans accountable to the state. Second, customized benefits. All the time, what we've heard in the federal health reform debate is that insurance companies want to do one thing, and that's avoid the sick. Well, in Florida, they've structured the incentives so that these 11 Medicaid plans, they're attracting the sick. 1 is run by the AIDS Healthcare Foundation, gives great benefits to people who are HIV positive. 1 gives pregnant moms home-delivered meals after they give birth. 3, they have choice counselors. How many times have we heard when we talk about school vouchers or Medicaid vouchers that the poor can't choose for themselves? Well, in Florida's Medicaid reform, 70% of patients are actively engaged choosing their own Medicaid reform plan. That's because they have the help of choice counselors, only 30 people hired by the state to help them pick the plan that's best for them. They get $125 a year for healthy behaviors like quitting smoking. And finally, this is most important, Medicaid is a safety net program. And quite frankly, it sucks. It sucks really bad because Medicaid patients think they have access to care. They have their Medicaid card.
That is the academic term.
It does. I mean, it's absolutely the worst coverage mechanism. The only reason why the ACA did it is so that it could export most of the cost onto the states. Medicaid is a horrible program. People can't get in to see a doctor. Medicaid reform in Florida says if you're on Medicaid and you have coverage through your employer, you can opt out of Medicaid entirely, take that money and buy coverage for yourself and your entire family. So what has happened over the past 6 years? Florida is saving $118 million a year with only 5 counties in this reform pilot. Once it goes statewide, it will save $1 billion a year. In fact, in the back of the room, you all might have seen this handout. It kind of gives a little perspective on Florida's Medicaid reform, and it actually breaks out the savings to your state if you implemented Florida-style reforms. In fact, if Florida Medicaid reform was its own state, it would have the 2nd lowest per person Medicaid costs in the country. So it's saving money. It's also making patients healthier. They have better access to specialty care than even with people that have private insurance. This is a great reform plan. And if I could just add real quick, my organization is the Florida Foundation for Government Accountability. We have raised over $1 million to launch Project Medicaid Cure. And what we want to do is deploy people into your states to help you enact patient-centered reforms like Florida's. We have legislators that are willing to come talk to you. Governor Jeb Bush is very involved with our project. And my contact information is on the handout. Please feel free to give me a call or send me an email, and we'd be happy to come to your state and talk about some reform options.
Thank you, Christie. I can just add one more thing to that, and that's that I hear lots of different examples cited from Medicaid reforms that have happened in other states. There are positive examples in other states, but from my perspective, this is really where it's at. This is the gold standard, and so I would encourage you all to pick up that handout and to follow up with Christie afterwards. Judson, if I could go back to you, in terms of what you've seen proposed at the state level, and obviously many states have proposed different responses to the president's law. Some of them are just political standpoints. Some of them have a little bit more meaning to them. Missouri is going to have a vote on the exchange, in November, for instance, a ballot issue. What are some of the things that you think legislators ought to be doing now in terms of preparation for what's going to happen after the election, regardless of what the outcome is? Are there certain things that we should be laying the ground for now in terms of state-centered reforms that we can get a head start on?
That's a good question. There absolutely are, and I believe Christie can remind me, was it an ALEC model bill that allowed the states or required the state legislatures to approve whether their state opted into the exchange or not? That might have been one of mine, actually.
Yeah.
We hadn't passed it in Georgia, but we've had a number of them. And I think there's 5, 6 states that actually passed that, which is critically important. Obviously, it seems to be too late to push that forward in your own state today. But I've been one, and a lot of you are as well, because I know many of you, to continue to advocate patient-centered reforms, free market reforms in your states. I wouldn't give up. Obviously, we got another sessions coming up in 2013, and we'll have had the benefit of seeing, hopefully the benefit of seeing what happens in the presidential elections in November. But Christie touched on a number of great points. Let's say we have a bad day in November. You still should push hard, I believe, for what they've done in Florida. I've been watching, from the state, just next door, and we've looked at that for a number of years and what they were doing in Florida, and you get a lot of pushback. We had pushback from, we call it in Georgia, the Department of Community Health. It's your health department in the state. We've had pushback from them in implementing some of those reforms even over the last couple of years. They're all looking for what I call the federal crack dollars. It's a bait. I mean, I've been saying this for a while. They give you money and then they gradually pull it away and they say politically, let's see what you're going to do now. You've got a new entitlement or an expanded entitlement in your state, and you don't have the political will or the capability, frankly, to reduce that expansion of whatever. And as Ben mentioned a minute ago, is last I checked on April 15th, we're all paying, or many of us are paying state, we're all paying federal taxes, and it comes out of the same pocketbook. So it's not drawing down federal tax dollars. I hope I never hear that comment again. It's not drawing down. I mean, I'm from Georgia. There's one other legislator here from Georgia. If I'm taking it from Rhode Island or Texas or Maine or any of your other great states out there, you don't think I'm drawing it down. You think I'm taking it away from you. So let's get beyond that drawdown because it's just a gimmick. Also, take a look at this. It's kind of a little bit beyond the question, Ben, but if you get your state hospital association to advocate for or against the Medicaid expansion, call your own individual hospital CEOs. I have found I represent more hospitals in the state of Georgia than anybody else except statewide officers, just because where I live in Metro Atlanta. Call each of them, because your hospital associations don't represent all of the hospitals. Just like in your own caucus, your majority leader, your pro tem or whatever, probably or caucus chairman probably doesn't represent 100% of the legislators in your own caucus. Same sort of theory. So find out what's really best for the individual hospitals. I'd suggest when they get a whole lot of Medicaid money, that's when they're going to be pushing more for it. But once again, look at I think there's a real opportunity on the Medicaid side, on the reform stuff that Christie's talked about and what they've done in Florida. Tremendous example and models, and I'll be the first to give her kudos, because when she said she'll come in, they will be there quickly, and continue to push the free market reforms across the board, because the people that you represent are dependent upon you and me to be advocating for that. And at the end of the day, whether Congress does their best to defund implementation of many provisions of Obamacare, I don't know if the November elections are going to be the last look at it if we lose. I think you'll continue to see it self-implode, because financially it's not sustainable, and we're calling it a tax now, but many of us have been calling it a tax for years. It's a tax that we can't afford to pay.
If I can add, one thing I forgot to mention is Florida's reforms were started under Jeb Bush, but in November, the Obama administration actually granted Florida permission to continue with its waiver. In fact, if many of you were at NCSL, you might have been in a healthcare panel with Cindy Mann, who directs Medicaid for the Obama administration, and she said during the panel that Florida is a great example of a good state solution. So if you're talking about something that you can do regardless of who's in the White House and who wins in November, something that's a bipartisan reform, Florida really is it.
Jill, I want to go back to you, and then we'll throw it out for questions. Could you talk a little bit about the video project that you guys have put together?
Right. So as a member of Docs for Patient Care, we went to Washington one year, and we got there the day after they passed PPACA, the first part. And then while we were there, they were doing the reconciliation back and forth. So when I got back from the trip, I decided to go ahead and read the law. So I read it outlined, and I was just astonished at what all is in it that people are not hearing about at all. So I outlined it, and I started giving talks on it, and some of the people that I gave a talk to helped me put together a series of a 7-segment series on YouTube. So just look under Jill Vecchio if you want. I give my card, or you can see the spelling in your handout. But it goes through in plain English. Just goes through who's covered, what's it going to cost, how do the state exchanges work, how does it affect employers, how does it affect doctors and patients, what are the constitutional and judicial arguments that are now outdated at this point, and then what are some ideas for real healthcare reform, and especially the number 7, especially the very last one, ideas on healthcare reform, and you know it's stuff that just makes sense, and it's wonderful. It's a great discussion to have because you can't complain about something if you don't have a solution or an alternative. So this series gives you the alternative, and it is very basic. And you could send this on to your constituents. It's meant to be nonpartisan, not unopinionated, just not Republican versus Democrat. And then I have some other resources. We're also training docs. We have doc squads, which is we've been training docs in 15 states now to speak on healthcare issues. So if you have issues coming up with your exchanges, with any election issues in your state, if you have senators, we want to help people adopt senators, things like that. Our groups are here to help you get the message out. And people want to hear from physicians. And sometimes you as legislators may not have the connections that you'd like to have. Please contact me or go to DocSquad, DocSquad.org. Contact us there on the website. And the videos, the YouTube videos are also there as well. And we can help you get connected with whatever you need to help you get the message out there from physicians.
Let's go to you all for questions. Kendall is there with the microphone.
Yes, there will be questions, but we ask that when questions are completed, you please remain seated for closing remarks.
Okay.
Thank you. Tom Buford in the Kentucky Senate. Question on healthcare exchanges. Christie may have the most talent in this area, is my experience with her. Situations dealing with the healthcare exchange, I met with our congressman from Kentucky, one of them, and he said this argument concerning the federal government will put you into a federal exchange if you do not do your own state exchange is a hollow argument, that there is not a bureaucracy, there is no funding, and they could not create it in time for January of 2014 to do it if they wanted to, and that this is an argument to press the states to experiment in this issue. And even in Kentucky, our governor says we're going to create the exchange. We took the $50-something million of your taxpayer dollars to hire 250 people, of which they say 100 of them will disappear once we get it directed, but then we rent and lease a building, and they have already said that we will not exchange with any other state. What is the purpose of this? We could not do an internal exchange in Kentucky if we do not satisfy Anthem and Blue Cross, that does 74% of the state currently, and Humana, who is based in our state with their home offices. This seems a bit ludicrous, a waste of money, and according to our Congressman, Mr. Guthrie, great guy, he says, don't know why you're doing this. It's never really going to take on a federal step to put you in. So that is just a blatant lie from those who tell you need to form an exchange or you will go into the federal exchange. I'd like your responses.
Christie, do you want to go?
Where do I begin? My goodness. You're right. So the Kentucky governor signed an executive order, as had 3 other governors, Minnesota, Rhode Island, and Mitch Daniels of Indiana, unfortunately. He's actually not great on health care. Yeah. Well, he's great on a lot of other issues. 3 governors have signed executive orders, many other governors taking down these federal grants. It's amazing the bribes that I call them bribes because right after the ACA decision was handed down, Kathleen Sebelius put out a press release saying, you don't even have to pay back the money. Even if you don't want to do an exchange, just take the money, figure it out, and maybe we'll work something out in the end. Here's what you can do as legislators. You have the power of the purse. The governor can get the grant money, but you have to appropriate it. I tell you what they did in New Hampshire. I think we have some New Hampshire folks in the room. There you go. Governor Lynch in New Hampshire got, I think it was the $1 million exchange planning grant. And the New Hampshire appropriations committees in the House and the Senate, they said, you know what, we're freezing all of the money and we want you to send it back. So you can get $1 million, you can get $2 million, $5 million, $10 million. There is no way we're going to let you spend it. That is a really good tool for you all to fight back. Second of all, the federal exchange versus state exchange. If you're serious about blocking Obamacare's entitlement spending, you want to let the federal government own this. The reason why they're doing this, all these exchange bribes, is because they can't force you to set up exchanges. It's unconstitutional. What they want you to do is to take the federal money and also take all the flack for them when things go wrong. If you're serious about blocking Obamacare's entitlement spending, you will place it all in the federal government's hands. Let them own it. They've given states nearly $2 billion in exchange grants. They've only spent about $150 million on the federal exchange, to your point, Tom. So yeah, let the federal government own it and fail. And when things go wrong, you're going to send them to Washington rather than sending them to the state capitol.
And just to follow on one quick point on that, the federal exchange has been there's a complete lack of transparency there. We don't even know what they're spending the money on. And the general impression that I have gotten from people in the know on Capitol Hill and even a couple of folks within HHS, I worked there and still know a couple civilian. There's just no advancement there. It is slow going for them.
The only people who know less about the healthcare law than we all do are the 700 people that Kathleen Sebelius hired to actually write the regulations. It's true. So anytime when there is a point of conflict, you know what? Send a Medicaid waiver. Tell her you're not going to do the exchange. Send back the money. Anytime that you can create a conflict point, you make them run around in little circles. And the more time they have running around in little circles, the less time they can spend implementing this horrible and anti-patient healthcare law.
Amen.
Yeah, Dave Dio from Iowa. I was curious, I wanted to hear a little bit more about this whole maintenance of effort and the ruling and how that's going to affect the relationship between the feds and the state governments. We had an issue in Iowa that dealing with, just this past year, dealing with Medicaid dollars for Planned Parenthood and whether they get priority over those dollars for family plan, for women's health care. You know, how does that affect whether the feds can require us to do certain things in that type of an area? I was also curious about just other programs like education, you know, and transportation dollars. There's a lot of other areas that they bribe state governments to do certain things with the threat to withhold money, and I was just kind of wondering about your thoughts.
Do you want to talk about South Dakota versus
Oh, you can go ahead.
Maintenance of effort. Maintenance of effort, again, it was part of the CHIP reauthorization, part of the stimulus in Obamacare. It goes away in 2014 regardless. But again, the state of Maine saying we're going to cut Medicaid eligibility back because the ACA decision said that you cannot impose new conditions on pre-existing money. I think that's a very interesting case to watch. How it affects other areas like education and what have you. I think now the door has been swung wide open. There was a Supreme Court decision called South Dakota versus Dole, which basically was about states lowering their drinking age in order to get federal transportation funding. And the Supreme Court ruled that it was not coercive for the federal government to impose that on the states in order to get the funding. But now with the Medicaid decision, and I think transportation funding is about 5% of state budgets. Medicaid funding is about 30% of state budgets. So we now have this window between 5% and 30% where we can relitigate over other programs like education and what have you.
And I would just say that in terms of what the Supreme Court did here on the sort of coercive, non-coercive thing, and just as they did with the mandate, you know, at what point is a mandate and not a mandate? This is definitely a Potter Stewart sort of, you know, I know it when I see it kind of thing. And so now this is an opportunity for us to test that and to find out, you know, what the point actually is where this is going to happen. So that's going to be litigated out.
Mine's kind of a two-pronged question because Arkansas is blazing new trails when it comes to healthcare. I appreciate you coming to Arkansas. First of all, Arkansas is not creating a federal exchange or not allowing a federal exchange. It's not doing a state exchange. We've actually, our liberals have actually come up with a hybrid because conservatives were able to block implementation language. So we've got a federal facilitated exchange, which is basically a federal state hybrid that we're now dealing with. And so I would like to maybe hear you comment upon that new creature that's been created. And it's just crazy how they're making things up as we go along. I mean, they really are. We're doing everything we can to block them, but at the same time, if we can't do it legislatively, then the governor or the executive branch and our health insurance department is basically, skirting different things, kind of like they do in Washington, D.C. when they want to get things through. So that's kind of my first point, if you could kind of touch on that. Second thing is in Medicaid, going to the Medicaid, our Department of Health has actually come out and said, hey, if we take the Medicaid expansion, Arkansas will save $372 million over the next until 2020 because
Head
of all
your
this
health
federal
department
money.
is a socialist.
Yeah, because of all this money coming in, it will stimulate our economy because of all this new federal government spending. So the state of Arkansas will save $372 million. And my specific question there is, how can you rebut that type of argument? And then the second thing I haven't heard of is if the governor, who is a liberal, says yes to the Medicaid expansion, but we have a conservative legislature, and we come in and we say, no, we're not going to appropriate the money, will we be obligated to? Will basically, if the governor says yes, that we will then be obligated to have to fund 138 versus 100? So
Judson, why don't you take the first part, and Christie, you want to take the second?
A bunch of good questions there. Christie was just telling me your makeup of your legislature. It looks like the Republicans may take the legislature in November. Is that correct? I see you shake. Yes. Which is great news for you from the questions you asked. And it ties also to the last question, is y'all have to appropriate. Now, it depends on the makeup and how strong your governor is from state to state, but they have a whole lot of discretion on their ability to move forward bureaucratically through executive decisions to direct your health department to do certain things. But at the end of the day, big dollar amounts have to come out of the legislature, I would assume they do in most states, and you should be stopping that. Now, I'd also say that it seems if you can't stop the modified exchange, or however the Arkansas-based exchange based on this other piece, which obviously it seems, if it hadn't passed, it seems like you could. Otherwise, I go on defensive and shoot attack them on all fronts. Attack the exchange and do everything you can to put big bullet holes and shoot a hole in the side of the battleship, if you will, just so when it gets implemented, it really doesn't have any teeth to it. I'd be happy to explore stuff because I'd like to be creative on some of these things, as some of you all know. And then two is, I'd attack them on other things. I don't believe that cross-state purchasing health insurance is the end-all, but I drafted legislation 5-6 years ago and introduced it every year for a bunch of years. And we got it as an ALEC model bill. Thank you very much once again. And there's actually an improvement to it. So if you actually are interested, call me because I'm interested in helping you out. I've helped out some other states. There's more of an improvement than the ALEC version that I think even has better legs and economically makes sense. But whether it's that or wellness incentives, I'd attack them on so many different fronts that the exchange is difficult. I'm kind of getting into some strategy side of things, but I'd be happy to brainstorm with you there. But yes, stop it on I'm not sure the makeup of your legislature there, but through appropriate, yeah. But in the end, if you've got it, if you have to have it, your own version, do whatever you can to make it so neutered and neutral that it's not going to really make a difference, and no one will actually practically be able to put it in place.
I've actually looked at Andy Allison's projections, just his top line numbers, and I think he's one of the Medicaid directors that knows his stuff. I think that's what you're dealing with. But you can also use your oversight powers. You all are legislators, you have committees, hold hearings, hold a bunch of hearings, haul them in. Say, listen, I want to ask you, how does it make sense if it saves Arkansas $300 and some million if we expand Medicaid? Who is it costing? Right? So is it costing the magical federal money tree? If we put more people in Medicaid, what's that going to do to access to care? I would suggest that as you're looking at these numbers, question some of the underlying assumptions. In fact, some of us in DC are working on 10 questions you should ask on Medicaid expansion savings, because we're hearing a lot of this from other states. And I am not a numbers nerd, but I am a health policy nerd, and we're going to kind of come together and make sure that you guys have those questions when you are ready to do it. As far as getting creative, so you're saying if you have a Republican legislature and a Democratic governor, and the governor says we want to do the Medicaid expansion, what happens? Well, they have to file what's called a state plan amendment. So every state has a Medicaid state plan, and in order to accept the Medicaid expansion, you have to file a state plan amendment saying our Medicaid was here, and we're going to now increase eligibility to here. Here's the change to our Medicaid state plan. Thinking about creativity, what about a bill that says any state plan amendment has to have a 2/3 vote in each house? Or put some other kind of conditions on the state plan so that the executive branch can't unilaterally do this without your approval. One interesting thing is in South Carolina, back when Governor Sanford was governor, he's a Republican, they had a Republican legislature. He went forth with actually a really great Medicaid plan, and the legislature took him to court over it and said, heck no, do you have the authority to do this on your own? I mean, there's another legal option for the legislature. Now, things are so acrimonious, were so acrimonious in that state that it got to that point, but maybe you'll get there in Arkansas as well.
Just to follow up too,
Sure.
on the piece we know with the Medicaid expansion, you're going to get a lot of individuals they've chosen not to participate in Medicaid. Whatever that percentage is in your states, it may be 10%, it may be 15, 20%. That number quantifiably is a big number. It's a big cost to the taxpayers when those people come out. So that's a follow-up question. Christie was mentioning a series of questions. Is this $300 million or so savings actually not a true number? Because when you account for that too, is it really a $300 million cost or even greater?
In fact,
cost?
to
Know your
Jill's
questions.
earlier point with provider rate cuts, I know that in Arkansas, 35% of the quote Medicaid expansion savings comes from cutting provider rates. So what you want to do is when you have your little hearing and you bring your Medicaid director in, your number 2 witness is going to be a doctor saying, well, our Medicaid director said that we're going to save $300 million. However, you're going to get your rates cut by 35%. Do you think you're going to go for that? And then you create a little dynamic there.
Do we have time for one more?
We have one more question. Again, please remain seated after the panel. If you would like to speak with the panelists, please do so after closing remarks.
Okay. I think right up front here, or nope, there you go.
Hi, my name is John Garvin. I'm a job creator in the People's Republic of Illinois. I have a real quick question. Max Baucus, the Senate Finance Chair, was recently interviewed a couple weeks ago, and somebody pointed out to him this really horribly drafted bill called the Affordable Care Act states clearly in the statute that the tax credits for buying through the exchanges are through state exchanges, not the federal exchange. And he kind of puffed. No, the intent was this. It's for all exchanges. What's it going to require to? Will it be a regulation to fix that, or a congressional act? What would be required? Because my understanding is that it's only supposed to be through the state exchanges.
So this is in flux at the moment, and just to, I'm glad you cited something from Baucus, because Baucus himself, in the course of getting this law passed, one of the things that had to happen was it had to go through his committee, and the only reason, and during a debate about it, which I believe it was Ensign who brought it up. Senator Ensign brought up that it actually was not appropriate for it to be in front of his committee because of the way, why isn't this in front of health as opposed to finance? And one of the reasons that was cited in the course of that was the fact that the reason for being able to put it through Baucus's committee was that these subsidies were only available through the state exchanges as opposed to something that was from the federal level. So Baucus himself is on record saying that. This is a critical issue. The problem is that the Obama administration has been utilizing the IRS to a greater degree than prior ones. Let's just leave it at that. And not just in the form of audits. In fact, the IRS is proceeding as if these subsidies were required to be distributed throughout all the exchanges and not just the state level ones. That is something, though, that can be reviewed by Congress. And already there's a push forward for it to be under review in the House side. There's letters that have gone out. In fact, just yesterday we got a letter sent to us asking whether we would sign on to it to work with the members who have introduced something in both the House side and in the Senate side to roll back this IRS rule, essentially, that's been created, saying that the law says something that it clearly does not say. And in terms of what's going to happen there, I doubt that it will actually get called up in the Senate, but it's not something that can be filibustered. And so because of that, you would actually have, if it does pass the House, you would likely be able to force a vote on the issue, which is not something that I think a lot of people want to be voting about in the run-up to the election, which at least will make the issue known. And it's also something that, because it's an IRS rule, is very easy to reverse. A future administration would be able to reverse it very quickly, and that's something that you should keep in mind as well. I know that we're short on time, and so I just want to leave you all with this. This is not a fight that's going to be easy. I think that there may have been some people who had the impression that the Supreme Court was going to bail us out, and we're operating under that assumption, and we're proven wrong. I think, unfortunately, this is something that we are going to have to win through the tougher battle. We're in sort of the beginning of Act 2 of this, and I would encourage you all, because I think that this is something that you should all understand is an eventuality that was anticipated by the founders. It was not something that would have surprised them. Sam Adams once wrote that if ever the highest seats of government should be obtained by vain and aspiring men, the country will stand in need of experienced patriots to prevent its ruin. He was talking about you. So with that, thank you to our panel. And if you all stay here, I think Joe has some closing remarks.